All right. Hello and welcome back. I'm your host of the Doc Buddy Journal, Eric. Here at Doc Buddy, of course, we deliver healthcare solutions that take the pain and cost out of broken workflows like OpNote, which gives ASCs the power of instantly generated operative reports approved from the point of care. You can learn more about OpNote and our other solutions at docbuddy.com. And today we're joined by Dr. Greg Collins. Dr. Collins serves as assistant professor of professional practice at Texas Christian University, the School of Nurse Anesthesia. He's operated his CRNA practice since 2006 across various settings. In addition to his civilian career, Dr. Collins has a background in the military, having served as an officer in the U.S. Army Reserve. His service record includes downrange deployments in 2008 during Operation Iraqi Freedom and in 2011 for Operation New Dawn. Dr. Collins, thank you for your service and thank you for joining the show today. We're excited to have you here.
Yeah, thank you, Eric. I really do appreciate the opportunity to speak with you today.
Well, it's going to be fun. We're going to have a good time here. Maybe not as good of a time, though, as we're going to have in Orlando next week for the ASCA annual conference, where you are a speaker. And if I'm not mistaken, your speaking slot is titled Improving Your Bottom Line? Anesthesia Models Are the Answer. And I think that's Friday afternoon. So before, we don't want you to don't want to spoil any of your talk there, but give us a taste. What can some of the ASCA attendees expect there?
Yeah, so really what we're going to be talking about is a concept that we call the driven anesthesia model. And I think it's the title obviously implies its implication for an ASC. I kind of want to so Eric, if I could, by kind of briefly introducing you and your listeners to, or maybe many to certified registered nurse anesthetists or CRNAs, because they really do have a critical role in this efficiency-driven model that we're promoting. CRNAs practice nurses who specialize in anesthesia. They've been doing so for over 150 years, really since the Civil War in the United States. If you look at a map, CRNAs are the primary anesthesia providers for about 80% plus of rural America. And often, as I can attest to, they're the sole anesthesia provider in downrange military medicine. Work in a variety of practice settings. Anywhere where anesthesia is delivered, you're likely to see a CRNA there on the stool. It's funny. Introducing or maybe what a CRNA is. About 25 years ago, when I was looking to get into this profession, I was handed through some net a VHS tape, and the copy of the title of the VHS tape was called "The Best Kept Secret in Healthcare," and it was I think it was Nightline expose, a little brief synopsis of what CRNAs were, and that title always stuck with me, "The Best Kept Secret in Healthcare." Really, that kind of to their mystique, because nobody really knew who they were. You'd show up at the hospital and somebody would put you to sleep, but you didn't really know who that person was or what exactly they did. And I'll tell you, in 25 years, it's definitely changed. We can't call it the best kept secret in healthcare anymore. CRNA about 50 million anesthetics a year now, and if you've had an anesthetic, in the last 10 years, it's a high probability that was a CRNA that provided that.
Yeah, I appreciate the primer there, and some of that new familiarity or refound familiarity. And this is obviously an important topic. There's an ongoing cataclysm, a lack of anesthesiologists and of anesthesiology providers of all levels. So that CRNA is the linchpin that, in my view, is holding it all together for now, as you see this exodus from the career by
No,
the anesthesiologist.
Yeah, that's absolutely true. And I think I plan to elaborate a little bit on that in Orlando on Friday. But it's a big market disruption right now, and the provider shortage is a primary driver of that market disruption. And I believe our organization feels strongly that I appreciate the way you described it being the linchpin. I think that the flexibility of the role of the CRNA really fits well with the current shortage. I know on the education end, we're ramping up our efforts to create more CRNAs to really get more people in the workforce. And, with retirement, with the baby boomer generation creating more demand, it's tough. And I think that we're always looking to fill those gaps. And I think really the CRNA is the ultimate model, if you will, to fill those gaps.
Yeah, how could it not be? You love to see the states sort of loosening restriction and regulation and allowing more independent practice by CRNAs. At least I do.
For sure. Yeah, for sure. Obviously, we advocate for that as well.
To bring us back, I kind of dragged us off topic here, Dr. Collins, and it's a great topic. But how does that refresher around CRNAs relate to that efficiency-driven anesthesia modeling?
Yeah. Thank you for asking that. It really, when we talk in terms of the efficiency-driven anesthesia model, I'm really talking about a concept that's built around a collaborative practice between CRNAs and either physician anesthesiologists or surgeons, kind of depending on the facility, depending on the culture and the needs of the facility. And the intent of that is to maximize flexibility. It's really structured to promote flexibility of the workflow of the surgery schedule, rather than forcing the surgery schedule through some arbitrary anesthesia practice model that emphasizes a bit more so than it does patient care issues. And I think when you kind of look at the workflow, and I know you guys are familiar with this, the daily workflow, daily surgery schedule in ASC, there's always choke points in the morning and always choke points at the end of the schedule. And this efficiency driven model, I think, has this plug and play type mentality that allows kind of the lessening of that burden of those choke points, and it really allows the ASC to dictate that workflow rather than forcing it through that arbitrary anesthesia model where there's provider redundancies, there's people watching people provide anesthesia, and we're more interested in helping the facilities really uh, uh, allow them to promote and to set the tone, if you will.
And related to those choke points, do you find those are harder or better or the same when we're talking about anesthesia that is employed by the center, or are those choke points really more vicious when we're talking about external anesthesia to the ASC?
Well, that's a good question, and I don't know that I can answer that completely. I think that it's probably a combination of both. It's somehow related to both. I think that the concern is always increasing flexibility, and I think that if you have ultimate flexibility where it's a next man up mentality, everybody is able to do everything. Monitoring room, provide operative assessment and planning, procedures like nerve blocks, things like that. I think that it's the efficiency driven model really operates on this best athlete in the best place, if you will, or next man up mentality.
That makes sense. And to kind of expound on my thought there of internal versus external anesthesia for a surgery center, obviously, we're looking at this through the lens of ASCA. We'll have many ASC administrators and owners and some surgeons and some anesthesiology providers there. But for those at ASCs where they have a relationship with an external anesthesia provider or group or groups of different providers, sometimes that can be a little bit of a black box to the ASC. We have our block times and we just do the very best that we can. But we're in a world now with shrinking reimbursements. We're in a world where block times need to be managed pretty ruthlessly, not only for you and your surgeons, but down to the individual case, down to the profitability by the minute for really tightly run ASCs. So from your perspective, what would you tell an anesthesia team or an anesthesia group to help build a successful relationship with the surgery centers in their market?
I think that's all related to transparency, and you mentioned the idea of the black box, the great secrets that each of those groups kind of hold and refuse to share with one another. And I think that ultimately eliminating those secrets and kind of being transparent, the anesthesia group, or whether it's a management group, whether it's even internal providers, I think there needs to be transparency on the side of the anesthesia provider that says, here is the market salary. Here's what we have to have people sitting on your stools and providing anesthesia, and we need in terms of your payer mix. Here's what we need in terms of the way the flow works of your specialty lines that you offer. But then on the side of the ASC too, we need transparency from an anesthesia standpoint. Does that ASC intend to grow, add service lines? What's that going to do to their payer mix? Do they intend to draw down a service line that may have been profitable for the anesthesia group that it's no longer going to be in existence? And so I think that kind of culture of transparency helps with that, and it helps on both sides, and really allows the ASC and the anesthesia management group or group of anesthesia providers to kind of align their goals together, that both their financial goals and their practice goals. And I think by doing so, by being transparent, kind of eliminating that black box, I think that we see, and I've seen this in my practice as well. You see that they're both sides, that both sides can adjust, both sides can can to increasing demand, decreasing demand, changes in payer mix, and that's kind of why I think being transparent is most important.
Well, you're kind of blowing a dog whistle in my direction, talking about transparency, talking about payer mix. I would imagine that transparency now, in a post No Surprises Act world, transparency and communication, going beyond just being transparent, but proactively communicating, around where you're in network, where you're not, and hey, Eric is coming in for a scope, and he's out of network for us. What are you going to do about it? Because I can't just stick him with this bill anymore. And that's not the right way to phrase it. That would be how the patient observes the billing to happen, not that the anesthesia group would be viewing it that way. So as I hedge my statement there, in this post No Surprises Act world, how does that transparency and communication change, or what needs to happen now that didn't need to happen before?
Well, some of it's being forced by the credentialers, right, and the governing bodies and by the federal government. Sometimes, you have to, for an ASC to have a contract with an anesthesia group, that anesthesia group must show that they're in network with the payers that are at the ASC. And I think because of the No Surprises Act, because of that, I think that it's forced transparency, which I think is a good thing. Obviously anesthesia management groups, particularly the big anesthesia management groups, have differing opinions on the No Surprises Act. And I think, for good reason, obviously, but I think that I think it's the playing field that we're playing on right now. And I think that our the demand of us is to adjust to that playing field. And like we mentioned, I think transparency is the answer there.
Well, and one of the things that is potentially helpful with advancing that transparency and being able to communicate readily and easily is technology. ASCs traditionally lag pretty heavily in technology adoption compared to their peers at the practice and at the hospital. Obviously, DocBuddy, we're pretty well versed in the technology and use at A by the ASC. What we don't interact with so often though is the anesthesia, the independent anesthesia group and their interaction with the ASC's technology, for better, for worse, or something in between. What are your thoughts there on anesthesia building that great relationship with the ASC? Is it access to the technology in the facility, or something else, or different technology?
No, I think it's access is a great opener for sure. I think the access has to be provided there, but I do think it's really incumbent on the anesthesia group to trust that technology from the ASC. There's all the matrices that are built. Sometimes they're a little bit cumbersome to what our schedule should look like, but I think that overall we have to trust the data. We have to trust the technology. And I think as the efficiency driven anesthesia model lends, make those adjustments, whether it be case starts, whether it be, you mentioned the type of the schedule, turnovers, things like that. I think that we have to trust that data. We have to trust the data, but the analyses of the data. And I think that good initial relationship with ASC, if you can build trust early, through transparency, then things like technology, we can embrace those together and make that part of the culture, make it part of the culture to depend on that. As the technology improves, obviously that it should be more trustworthy. And I think that being able to depend on the ASC to provide that in a fair and equitable manner, and for the anesthesia group to respond appropriately to those analyses with staffing changes, with movement within the staff, so on and so forth.
That makes a ton of sense, and I'm really interested in your perspective here, because you have a new push, and maybe renewed is the right word here, that ASCs are making decisions on which types of cases they're going to do based on the projected profitability. So you're looking at your staff costs, your surgeon costs, your supplies, your implants, all the things that go into a successful procedure. Obviously anesthesia is a part of that, and if anesthesia is a different business than your facility, how does that change the equation, or what would be your pro tip for anesthesia teams to go into a facility and say, hey, look, we want to help you be profitable on every case you do, because we're not going to have any cases to help you with if you don't keep the lights on. So it's very clearly alignment of incentives. But what would be your recommendation to anesthesia teams there?
Yeah, well, I think that the ASC's understanding of how an anesthesia provider bill is generated is important. I think the more they understand about that, the more they understand that we're beholden to whatever CMS or a private payer allows for this particular case. There may be a delta there. There may be a delta on what it costs the person to sit on the stool versus what they're being reimbursed to sit on that stool. And that's, again, where that relationship is so important, because if it's profitable for the ASC, maybe not so profitable for the anesthesia provider, then the meeting of the minds has to happen to how are we going to do this? How are we going to continue to provide this service? Who's going to make up the delta? How are we going to make up the delta? And how are we going to move forward? It's usually reimbursements being cut. That's a big part of the market disruption. Those just continue to be slashed in the face of this demand, decrease in providers, and salaries going through the roof. Salaries now are at an all-time high, and so that gap between what we're paid to sit there and what it costs a provider on the stool.
Where do you think it breaks, and what do you do to fix it after it does break? Because it's not sustainable.
That's the $1 million question. That's I should say that's the multi-million-dollar question, right? I think that I mean, heard it forecasted that the end is near, and then I've also heard it. I've also heard the forecast of their prediction that who knows? We're continuing in this upcycle. I don't think the anesthesia market will settle anytime within the next 10 years. I would like to see that happen. I would like to see it happen just for stability. But at the same time, we can't do much to dictate the market. We're putting providers out there in as many numbers as we can. But demand, the increase in demand it is what it is, and it's upon the providers, the facility providers, the hospitals and the ASCs to make those changes, and also to understand what that means for the anesthesia groups, what that means for the provision of anesthesia in your location, and what that means for the addition of a service line, the drawdown of a service line.
Well, it seems to me, and I'm a layperson here, there isn't really a magic wand. Like you said, you can't. What can you do to impact market forces, either as a group, even if it's a very big group? You're still beholden to broader macroeconomic factors. But those much wiser than me have shared that the place to start is to get more people interested in going to medical school, first of all, and then secondarily interested in becoming an anesthesia provider. Is there anything you can really do beyond that? And I won't ask you, how do you do that? What would be your pro tip there? Because if you knew, you wouldn't be telling me you'd be in Washington. But is that a reasonable place to start? Just more anesthesia providers is the step one here.
I think that's foundational. I really do. I think that's foundational because the demand's not going anywhere. We try to make predictions in the market, but I can boldly predict that the demand will just continue to increase. Obviously, the training and education of MD anesthesiologists, of CRNAs is it can't. So, I work at city and I understand what that means to us here locally, but we can only fill so many seats. We're limited, as is everybody, with the seats. There are nurses now. I mentioned certain nurse anesthetists being advanced practice nurses. There are nurses post-COVID in the ICU that are making money that to be a pretty good motivation to go to CRNA school, and they're making money now that they never have made before, and that's a little bit of a detractor. And so on the education side, we've looked at kind of what that might mean to us in the next 5 years and 10 years. See less applicants, and I'll tell you that at our program specifically, and I think this is true across the nation, that the application process hasn't slowed down. I think, again, it's just unfortunately demand that's outpacing supply.
That had never occurred to me, that non-anesthesia nursing salaries were so competitive now with that advanced practice degree that it would detract from the interest. But the other second half of what you said, the demand is just so great that supply can't ever meet it. So coming back to our main theme, having said all that, there's a lot happening in anesthesia, the world of anesthesia. What do you wish ASCs would have a better understanding of as it relates to this?
Well, I think I wish they had a better understanding of the disruption, and I think I intend to introduce that significantly in Orlando. But that many times you mentioned that kind of disconnect between an anesthesia management group, anesthesia providers, and ASCs. And I kind of wish that they understood that they see a number many times on a budget line of salary and what will equate to eventually a budget line of subsidy for the ASC, and that's difficult for them to comprehend, and it creates a little bit of will. And I think that if they could truly understand the market disruption, truly understand the market disruption and also the forecasted market disruption, I would like that more than anything else, because we are in a peculiar position with that. And I think that we succeeding of profitability, but that's just related to salaries. Anesthesia management groups, they're also eating those salaries. They're the ones paying those salaries. And so they're the ones that are having to go back to the facilities and negotiate how are we going to cover this. I mentioned this on Friday, but a subsidy or an anesthesia subsidy or a stipend, that used to be a word that didn't exist in the ASC community. There was just no such thing. The ASC payer mix was always great. The ASC flexibility, the schedule, the types of cases that were done there really allowed an anesthesia management group to come in and operate that just solely based on provider reimbursement. And with reimbursement being cut, with those demands picking up, and with salaries now going through the roof, that's great for the CRNA or the anesthesiologist that's sitting on the stool providing anesthesia, but that's really putting a pinch on the anesthesia management groups. And I think that's what's generated things like this efficiency-driven model. They're looking for ways as well. The anesthesia management groups are looking for ways as well to kind of a little bit, if you will, that fall of subsidy, and that going back continuously to the facility and saying, look, in this job market, the salaries are continuing to increase. Our reimbursement is continuing to decline. We can't keep people in your facility if we don't do something about it in terms of a subsidy. And so that is a word that ASC providers are definitely learning a lot about in the last few years.
Give me your take on this, because what like the way I'm kind of looking at this, and maybe this isn't the right mental model, but if you're a surgeon at an ASC, like your very first step is to be credentialed with the payers whose members you want to do procedures for. Number one, you have to have that much of the revenue cycle intact. And this is tongue in cheek and maybe a little bit of a flippant comment, but like if I need my knee worked on, I'm not doing it without anesthesia. So as a surgeon, being credentialed and being on somebody's panel, and then having anesthesia that you can rely on, like those are the two things that you have to have. Otherwise, you're not treating any patients at all. That's the setup for where does this road lead? Does this road lead to surgery centers doing only the very most profitable cases, and obviously profitability being squeezed for them, where we're only doing the cases for big bucks, and like, oh, Eric, sorry, your elbow hurts. Well, why don't you go try the ER and see if they'll treat you? Like, where do we go?
Well, that's a good question, and I think that's something that ASCs in particular haven't had to consider before is, what is the number for anesthesia reimbursement in this particular given case? What is the anesthesia provider being paid for this? What does that mean then for our subsidy or our budget line on anesthesia in our facility? And I think that may be part of that transparency. That may be part of the transparency you mentioned earlier is they know what they're making. They know what the facility charges are, the facility reimbursements. They probably have a good idea about what the surgeon is making. Many times there's surgeon owners or surgeon partners in those groups, and so they understand that. But what they haven't had to look at is, what's the reimbursement for anesthesia here? And I think that's kind of why I want to introduce a little bit in Orlando to kind of show that this is something that they have to pay attention to. And from the anesthesia management group in terms of here's what we're going to make. If you give us this here's your list of procedures, here's your list of payer mix, and this is what we're going to make. That has to be transparent, and that will allow them, hopefully, the ASC to understand and do it without anesthesia. That's kind of the ultimate crux of this, right? Is that, and I think the government and the payers have figured that out as well. That if we need, we can cut because eventually someone will have to pay for it. And unfortunately, many times that's going to be the facility.
That just sets up the wrong incentive chain. That's going to get the incentives flowing to those high ticket procedures and nothing else. And then, what happens to outcomes for patients who are immobile when a simple procedure would fix that? And that's just a silly example, but that doesn't seem like a good place to go.
No, I agree, and I hope and I trust that the leaders in the anesthesia organizations and the leaders in the ASC space, are having those big picture meetings because I'm not sure that's going to get any better anytime real soon.
Well, on a slightly rosier topic here, and we can certainly revisit this path to a not good place with poor incentives, but on a little bit rosier topic, AI in healthcare is huge. You cannot throw a stone without hitting somebody talking about artificial intelligence or so-called artificial intelligence in healthcare. What are you seeing on the anesthesia front specifically? What are you seeing more broadly that excites you as a provider yourself? Like what is going through your head with AI in healthcare?
Well, unfortunately, or fortunately, maybe I'm a casual observer at this at the moment, and so I can't really wait to see where this goes. I think we mentioned the technology earlier in terms of analyzing efficiency, in terms of when to schedule cases, how to schedule those cases. I think that's the perfect setup for AI. That's the perfect setup for these a large model able to take that data and really quickly spit it out. It's incumbent on, as I mentioned, us, but also on the facilities and the surgeons to trust that data and say, if it's better for me to do orthopedic on this particular day because the model suggests that that's the case, that there's going to be more flexibility in our schedule, that we're going to have more people here, so on and so forth. I think that we have to trust that. I'll tell you where I am a little bit here with AI is in the practice of anesthesia, and it is blowing up. I mean, I've heard we just had a research symposium here with our doctoral students, and some of the things that they brought up and kind of teased out of the current literature was fascinating. There's large models now that will monitor patients' vital signs and these different data points, assessment data points throughout, and warn the anesthesia provider of an impending untoward event. At our facility, where we train CRNAs, we have AI that's built into ultrasound machines that can identify muscles and nerves, that can give some quantitative physiologic data in terms of I can put an ultrasound. Speaking of upgrades in technology, that ultrasound machine that used to cost $80,000, I can spend a couple of $1,000s, plug it into my phone, put it on the patient's chest, and get a rough. Now that's not a diagnostic tool. That is just a quick assessment thing, and AI has played heavily into that. I think that gosh, as this moves along, I'm really fascinated. Don't know much about where it's going in the business space, but gosh, on the practice front, it's extraordinary, and I really can't wait to see how this plays out. Luckily, I'm still young enough, if you will, to be in practice to see this happening.
Yeah, that is cool. And this is like the first time in my career that healthcare has gone so quickly towards something new in a tech sense. So I don't think we'll have long to wait to see where we end up. Some of it's kind of a hammer in search of a nail, but some of it really is pretty cool and making a real impact.
Indeed, and something
This
I
is a
think we have to embrace. I don't think we can, because you mentioned the hammer analogy. If we don't, we're going to be the nail really quickly. So I think we need to make sure we embrace that and learn how to use it to benefit everybody.
it's a literal Pandora's box scenario. You need to control what's coming out of that box, or it might end up controlling you, and not in a Terminator Skynet sense, but put it to use for you. Don't get competed out of the market.
Indeed.
This is a little bit out of left field at you. So obviously, with the medications that you use for anesthesia patients, there's a little bit of risk there. General anesthesia, you've got it down to a science, no doubt, but it still makes me a little uneasy as a patient to know that that's going to happen to me. I've heard this said, this is kind of a long walk for a short drink of water, Dr. Collins. I've heard it said on this show that one of the things that we're going to look back on in 10 years or 20 years or something kind of near term future is how insane it is that not everybody is utilizing personalized medicine. And by that, sequencing your genes. And let's forget about the privacy aspect of this for just a second, but being able to sequence somebody's genes to say, you don't give them this medicine, it's not going to work, or it's harmful and you wouldn't know it until it's too late, versus this is super effective. This will, they will not feel groggy upon waking. Do you have any thoughts on that side of medicine?
I do. In fact, one of my closest colleagues, who happens to be president of our professional organization right now, he's a CRNA with a PhD in pharmacogenomics, and so he and I can sit and talk about this all day long. And I think that the implications there, we're already seeing some implications in anesthesia with that. In terms of susceptibility to opioids, in terms of susceptibility to other drugs, the genetic identifiers there that are present. And I don't think we're very far away from you, Eric, showing to have your scope you've been talking about and handing the anesthesia provider a sheet that it's not a recipe by any stretch of the imagination, but it is a set of guardrails that's really going to allow me as an anesthesia provider to provide exactly what's best for you, to avoid what's not best for you, and to really customize your experience. I think that not only is that going to save a lot of untoward outcomes, but that I think has the potential to save money for facilities. I think it has the potential to save money for pharmacies, if you will. I think that really the options are unlimited with that. I'm anxious to see where that goes. I love to hear him talk about that, because I think that just the thought of it, it's a huge push, and I think that in that market. And I think that hopefully we will, as with AI, that's going to be something that hopefully we will embrace.
I'm with you. I think that's really exciting. I mean, that's, not to be too lighthearted or tongue in cheek, but that's like Jetson's level of future technology, personalized medicine. That's really cool. But just like we're talking about Pandora's box with AI, whether it's in healthcare or in the broader consumer world, there's no real regulation around it. There's nothing that protects patients from the use of AI in their care yet. There will be. There's not even anything for regular consumers, at least not at federal level. Certain states are contemplating it, just so none of my listeners get all whipped up that I'm wrong about that. But with personalized medicine, the fear, if I'm not mistaken, is that, like, what if my insurance company gets this information? They know I'm going to die in a year or sooner than I should. What happens to my coverage? So how do you navigate that? And I know I'm really throwing meaty questions at you, but would love your thoughts, because that's the fear for me. Like, that's my genes, and then somebody else has that information now.
That is maybe the ethical dilemma that we're marching towards there, right? And I don't know. I think that I have difficulty really depending on the federal government to come up with things like that. I think that hopefully the people that are in that space that are kind of developing that technology, we need to rely on them to say, hey, okay, now how do we shade this from people that don't need to see it? How do we allow the people to get access to it? But then how to get that to the patient? That's going to be the ultimate thing, right? And I think that's, gosh, I wish I could answer, Eric. I'm confident that's well above my pay grade at the moment, but I share your concern.
Yeah, yeah. I'm picturing sort of an a la carte menu, like give me my NSAIDs, my best NSAIDs, give me my best anesthesia medicine, and like that's it. I don't want to know any predispositions to any horrible, uncurable illness. Just keep that to yourself there.
I would agree with you, but there are some that won't. So what do we do with those people?
You know what? I'm a free market guy. I said let them pay for it and give it to them, but don't come crying when you get something you don't like. So
very good. Yes.
So as we kind of get to the end of our chat here today, which has been fantastic, what are you hoping to gain out of your talk in Orlando? What do you want your audience members to gain there? What's the big takeaway you're hoping for next week?
Well, I think kind of the big takeaway and the way I'd like to wrap this up is really we're going to, in Orlando, talking about this efficiency-driven model, kind of break it down, talk about the specifics, that aspect of it, if you will. But I want to leave you today kind of emphasizing again the role of CRNA in that. I think our training and our background in nursing, I do wholeheartedly believe that CRNAs typically practice with the heart of a servant. And I think that, believe it or not, and many of my colleagues would shudder at this statement, but anesthesia is a customer service business. We have customers, and our patient is obviously our primary and obviously most important customer, the one that we care about, the one that we train, decades for to take best care of. But that surgeon is also a customer. When I'm providing anesthesia for that surgeon, I'm providing that in a way that allows that surgeon to practice, allows that surgeon to do what he needs to do for his customer, the patient, but also to maximize his success. And I think ultimately, probably a VI customer is an ASC, and I think that anesthesia need to realize that. And I hope that that I trust that most of my colleagues, my CRNA colleagues, understand that and understand this customer service aspect. I really think, gosh, if you get the right group of anesthesia providers in the right facility, that rise in waters that will eventually float all these boats, including the surgeons, including the ASC itself, and also the anesthesia groups that manage these things. I think that it's ultimately in the culture that can be built between or within that relationship. I think that just makes the ASC more profitable for patients and more attractive for surgeons to come provide their care, and more attractive for payers, to be honest with you. If you're doing something efficiently, then payers are likely to pick up on that. They're going to pick up on that. And I think that allows, a good rise in water, and hopefully, everybody is successful. I think that rather than black boxing the anesthesia group, rather than black boxing those anesthesia providers, I think that genuinely we want to be part of the culture. We want to contribute to it. We want to help everybody be successful, because we know if that's the case, we know if more surgeons are operating with a better payer mix in a nicer facility, we're going to ultimately benefit from that as well. And I want ASCs to know that's kind of the paradigm of CRNA practice, but of all anesthesia provider practice. We stray away from that sometimes. We do things sometimes that are, seem to be more engaged in profitability. But I think at the end of the day, we're in a customer service business, and we want to treat the facility like that.
Really well put. And the ASC is setting a good example for the rest of healthcare, as you pointed out. Great for patients, great for providers, even great for our friends at the payers, which sometimes, don't always get a fair shake. But it's an important example for healthcare, because where else does that happen at the same time? It just doesn't. So as we wrap up, Dr. Collins, where can listeners connect with you? Are you big on any social medias?
I'm easy to find on LinkedIn. Easy to find. You can search my name and TCU School of Anesthesia, pop right up there. I'm Collins CRNA on X. I do want to your listeners, if you have any questions leading up to the ASCA, I look forward to meeting everybody there, obviously, as well. I want to a couple of webs and an email that will allow you to maybe get some information ahead of time and develop some questions. The best email to immediately these questions answered is help, HELP, at aana.com. And you can visit anesthesiafacts.com. There's a litany of information there. I plan on really teasing that up to next week in Orlando.
That's fantastic. And listeners of the show will know they can expect those links in the show notes in the description area. And on behalf of the entire Doc Buddy team, thank you for listening. Be sure you're subscribed on Apple Podcasts, Spotify, and YouTube, so you can always get the newest episodes of the show. And until next time, I'm your host, Eric. Talk to you again soon.